So I like to start my lectures with a picture instead of my title. So this is along Highway 56. It's the northwest corner of Montana. This is where I grew up. Just a really scenic area. So this is colon polyps and neoplasms. There are two websites Dr. Hughes and I have that have questions for the USMLE. There's my Twitter. I keep saying I'll go back on it, which I probably should do pretty soon. But I have some stuff posted still available there. And remember, I'm a forensic pathologist, but I have a really strong interest in teaching medical students, and I just have a really strong interest in general and organ pathology, natural disease, not necessarily as much trauma. And so I hope these lectures are useful to you. Here are two of my 3 disclaimers. Please pause, read this, make sure it does not apply to you. If it applies to you, don't watch the video. There's a 3rd disclaimer. Once again, pause, read it, make sure it does not apply to you. If it does, don't watch the video. The last one is, if you want, not many people have, but if you want to view my introduction presentation, it kind of talks about my teaching style if you want to understand why I'm doing that. So here are my references. So I start each lecture out with a question or two, and what this does is it increases retention. So pause, see if you can think of the answer, and then we'll discuss it at the end. So as far as types of polyps, this is from Robbins' Basic Pathology. It talks about hyperplastic, inflammatory, juvenile, which is also listed as hamartomatous polyps. But as you'll see on the next slide, there are other conditions that have hamartomatous polyps. And really a hamartoma, remember, is just a abnormal mass created by a disorganized collection of tissue that's normal to that site. And so I'm sure there's going to be some variation on each one, surge path-wise, but just in general, I think for medical students, knowing their hamartomatous polyps and knowing what a hamartoma is probably what's most important. And then the preneoplastic or the dysplastic, the adenomas. So here are some of the polyposis conditions. These are associated with neoplasms, but the actual polyps themselves that they're associated with are not. Hamartomas are not at risk for malignant change. So I listed the mutations there. I think mutations are actually useful to know. When they ask you questions on the USMLE, the answers are supposed to be all in the same category. So they'll all be a bacteria, they'll all be a pathologic change, a pathologic finding, a diagnosis, a mutation. That being said, it's a lot of memorization, and sticking to the main ones is probably most important, but there are the mutations associated with it. With the GI pathology, they're all hamartomatous polyps. The Peutz-Jeghers, it describes as arborizing, and so it's normal tissue there, but it has a disorganized feature. And it says the difference between Peutz-Jeghers and juvenile is that Peutz-Jeghers have a skeletal muscle, or have a muscle, sorry, not skeletal muscle, sorry, smooth muscle framework. They arborize on that, and then juvenile polyps, you don't see that. With these, it's good to know, I think, some of the things associated with it. Remember, if they're all the same, then they got to give you something in question that's different. So Peutz-Jeghers, the mucocutaneous pigmentation, very useful. Juvenile polyposis is associated with pulmonary arteriovenous malformations. Cowden syndrome has other cancers associated with it. Cronkite Canada has skin pigmentation as well. And then tuberous sclerosis, probably common enough and relatively important enough to know a lot of the findings associated with it. So renal angiomyolopomas, skin lesions, the ash leaf and shagreen lesions, CNS tubers, and also the subependymal giant cell astrocytomas, and then they can also have hamartomatous colonic polyps. So 2 polyp types are hyperplastic and serrated. They actually look very similar. They have a little like a jagged appearance of the cross-section of the gland. So hyperplastic polyps have no malignant potential, but serrated adenomas have some neoplastic potential. So I think serrated adenomas are a relatively new diagnosis. When I was in residency, which wasn't that long ago, I don't think it was known at that time that I remember. I only made that diagnosis. But a hyperplastic polyp has the up and down undulation of the mucosal surface at the surface of the gland, and then serrated adenoma goes into the depth of it. And that's the difference between the two. Inflammatory polyp is another type of polyp. This one has a polypoid shape, so you can see the top left, so it's a projection from the surface. And then microscopically, it's nice when the name describes it, but it's inflammation. So you see some mesenchymal tissue and then inflammatory cells there. So juvenile, which, like I said, also is described as hamartomatous, but remember, hamartomatous is a description, and several ones have hamartomatous polyps. but juvenile polyps are just one type of them. These, in contrast to Peutz-Jeghers, have no muscle. So if you look at this, you can see glands, you can see stroma, you can see blood vessels, but it's not normal. It doesn't look like a normal colon, so it's disorganized. So it's a disorganized collection of normal tissue. That's a hamartoma. Whereas Peutz-Jeghers, you also see normal tissue. You see mucosa, you see goblet cells, everything like that, but it's not in an organized fashion, and then it's arborizing based upon the branching of the smooth muscle there. And this is Cronkite-Canada syndrome. So remember, Cronkite-Canada syndrome was one that, at the time, from what I could read, has no mutation associated with it, and it has skin pigmentation, but it has hamartomatous polyps. So if you look at these polyps, you can see that you can see glands, you can see stroma, everything like that, but it's a disorganized collection. And so that's what you see with a hamartoma. So with the adenomas, these are the ones that are preneoplastic because they have dysplasia. And so they're benign, they're not invasive, but they can lead to a malignancy, and they can also harbor a malignancy. So when they remove a tubular adenoma, the pathologist will examine it, and sometimes you do find invasive adenocarcinoma within it. So the three types are tubular adenoma, tubulovillus, and villus. So tubular adenomas are composed of tubules, and villus have finger-like projections. Tubulovillus is some combination of them, which is, I'm going to guess, probably a subjective diagnosis based upon the pathologist's preference. Grossly, tubular adenomas are usually pedunculated, so they'll have like a stalk, whereas villus adenomas tend to be more sessile. Tubular adenomas are basically a collection of tubular structures, and then villus are finger-like projections, so you see these long projections of the adenoma. Malignant potential tubular adenomas is lower, and villus adenoma is higher. The way I kind of remember this is if it's pedunculated, it's off the surface of the colon, so it's less likely to invade. Whereas with a villus, it's sessile, it's right up against it, so it's more likely to invade. That's just the way I remember it. Size is important for an adenoma. If it's less than 1 centimeter, it has really low risk of malignancy, and greater than 4 centimeters has a higher risk, 40%. What that means is when they look at it, they'll think it's a tubular adenoma, and they look microscopically, and they'll see invasive adenocarcinoma. So a tubular adenoma, to the top left, the yellow arrow shows the adenoma, and then you can see the stalk, so that's the pedunculated nature of it, kind of like a little mushroom in a way. And then to the bottom right, you see its morphology. So it's glandular. You don't see invasion, but it looks like it could be invasive. You see high NC ratio, hyperchromasia. There could be some mitotic figures in there. You don't see normal goblet cells or anything like that. So this is a villus adenoma to the top left. It looks like it's familial adenomatous polyposis, but it's not. The black box goes around it. It was just, like I said, it was sessile. It was right up against it, and just went for a distance. And then to the left of it, the yellow arrow shows normal colon. So like I said, it's not familial adenomatous polyposis. It was a villus adenoma. And to the right of it shows its architecture. So you can see just long extensions, finger-like extensions of the mucosa. That's the villus. Then I like to put in a slide to break things up. So this is actually from the Moist Bison Range up in northwest Montana. If you're ever in Montana and you like animals, definitely worth a drive at night. There's a whole bunch of things you can see. So this is a pronghorn. I always think they're very beautiful animals, very fast too. So when you talk about malignant polyposis syndromes, these are the main ones. Familial adenomatous polyposis, where they have multiple polyps, and the more polyps you have, the more likely you have to develop cancer. It's associated with the APC gene. They can also have gastric adenomas. The MYH-associated polyposis is associated with the MYH, was a DNA mismatch repair gene. And this one, you can see sessile striated adenomas, which, like I said, remember, has malignant potential, and then mucinous adenocarcinoma. Hereditary non-polyposis colorectal cancer, or Lynch syndrome. Dr. Lynch was actually at Creighton when I was at Creighton. I never actually worked with him, but I only heard really good things about him. So this one is a DNA mismatch repair condition. Two of the genes associated with it are MSH2 and MLH1. And this one, like FAP, is autosomal dominant. You can see sessile striated adenomas and mucinous adenocarcinomas. The thing is that it's called non-polyposis because you don't see a ton of polyps, whereas in familial adenomatous polyposis, you see a ton of polyps. Then Gardner and Turcott are two other polyposis conditions. Gardner's associated with osteomas and some other lesions, and then Turcot is associated with brain tumors. So colon cancer and brain tumors. If they have the APC gene, it says it's associated with medulloblastoma. If they have the DNA repair gene, associated with glioblastoma, and then they have the adenomas and potential for colon cancer as well. So this is actually familial adenomatous polyposis. So if you look at the black arrows, that shows normal mucosa. So you can see widely spaced glands. You can see potentially some goblet cells in that. And then the blue arrows show the dysplastic mucosa. So you see much more tightly packed cells, higher NC ratio, hyperchromasia in that. And then to the top left, you can see abnormal, normal, abnormal, normal, abnormal. So you can imagine grossly what they saw was multiple polyps, that corresponding to the blue arrow areas. So this was familial adenomatous polyposis associated with the APC gene. So adenocarcinoma of the colon, it's the second most common cause of cancer-related deaths in the United States, outside of lung cancer. Usually it's seen in older populations, but 20% are less than 50 years of age. And remember, 50 years of age, I don't know if it's changed to 45 now, is about when people start getting their screening colonoscopy. So it's very important to consider because it does occur in a younger age. Usually male greater than female. It's from basically low fiber, high fat, high refined carbohydrate diet. And then the clinical way they present, they can present with iron deficiency anemia because you have a cancer that's ulcerating, it's bleeding, they get iron deficiency anemia. My thought, they can usually present throughout the colon, but those on the right side, it seems like are more likely to present that way because on the right side of the colon, the fecal material is more liquid, and so it's harder to cause obstruction. Whereas when it comes around to the left side, it's becoming more solid, and it's easier for a tumor that's constricting the colon to become more obstructing. But obviously, a left-sided colon cancer could also present with iron deficiency anemia. So anytime you have iron deficiency anemia in an older person, especially male, it's very important to consider the colon cancer. And obviously, anytime you have iron deficiency anemia, you have to explain why a person has iron deficiency anemia. So the mutations associated with even sporadic adenocarcinoma, the APC beta-catenin pathway, microsatellite instability or DNA mismatch repair, so same things as we see in FAP and hereditary non-polyposis colorectal cancer, and the CpG island hypermethylation phenotype. So the USMLE, I've been told, is very important, very much wants you to understand mechanisms, which I agree with because, treatment procedures, protocols, stuff like that changes yearly on things, but mechanisms really don't. And so if you understand the mechanism, you really understand why you're given certain drugs, how the condition might work and things like that. So here's my kind of hopefully simple explanation of the mechanism of APC. So APC normally is negative effector of beta-catenin, or it degrades it. So if you have a mutation in the APC gene, you're going to have more beta-catenin. That actually activates transcription. It activates transcription of the MYC and cyclin D1 genes, and then those lead to proliferation of cells. Anytime you have proliferation of cells, you risk the hyperplasia, dysplasia, carcinoma pathway, and then you develop a neoplasm. So colonic adenocarcinoma, here are just two. To the top left, these are from old specimens, and so they're kind of abnormally discolored, but you can see the lesion right there. And then to the right of it, you can see this ulcerated neoplasm. So the colon cancers could be more exophytic, they can be more ulcerated. To the right, actually stuck up against the abdominal wall and then eroded into the wall. So we talked about colonic adenocarcinoma. We talked about the hereditary non-polyposis colorectal cancer, and that we talked about mucinous adenocarcinoma. That would be to the right. So in a mucinous adenocarcinoma, you see the glands and you see a lot of production of mucin. That's the wispy blue stuff in the spaces. To the top left would be more kind of the standard, where you see just invasive glands. But these are both types of colonic adenocarcinoma, and there's probably more types than that. When you stage colonic adenocarcinoma, depth of invasion is very important. My understanding, and I think the staging for cancer changes quite frequently, but at one point, and it could still be the way it is, depth of invasion was more important than lymph node. So somebody who had less than halfway invasion in the muscular wall but had lymph nodes had better prognosis than somebody who had greater than half invasion into the muscular wall but no lymph nodes. That invasion halfway point was very important. So what I put here was that to the top right, the yellow arrow is the invasive neoplasm. The black arrow shows muscle, and then the blue line shows the boundary between the two. But obviously depth of invasion is important, lymph node metastases are important, and distal metastases are important. It oftentimes goes to the liver. It says except for the anal rectum, which has a different lymphatic drainage, and then it can go to the lung as well too. So to the left of it, that's liver, and you can see all the yellow nodules within it. That was all metastatic colonic adenocarcinoma. When you start talking about tumors of the actual anus, you're going to talk about squamous cell carcinoma. So just showing this, you can see the typical keratin pearls. Okay, so here's the question. So pause, look at it, and we'll go through it and come up with the answer. Okay, so a 62-year-old male presenting emergency for abdominal pain. He says that the pain has developed and worsened over the past 4 days. At first he had diarrhea, now he is constipated and has vomited if he attempts to eat. Physical examination reveals distension of the abdomen and reduced bowel sounds. He has no guarding or rebound tenderness. An x-ray of the abdomen reveals air fluid levels. Of the following, what is the most likely underlying etiology for his disease process? So he has a disease process that came on relatively quickly over the course of 4 days. He has developed constipation. He has distension of the abdomen, reduced bowel sounds, so the bowel's not running the way it should, and then the air fluid levels that would all go along with a bowel obstruction. So a bowel obstruction of those, the one that would be best would be the colonic adenocarcinoma. And obviously the ruptured appendage can cause peritonitis and can slow down the bowels, but not be unusual in that age group. Perforated peptic ulcer, same thing. Metastatic carcinoma of the peritoneum probably wouldn't do it. And then infarcted Meckel's diverticulum could cause a small bowel obstruction. But the one that's the most common, and what my understanding too is that ultimately you want to pick. There might be more than one possible answer, but there's one best answer. So of those, in a 62-year-old male, given how common it is, go with the colonic adenocarcinoma. So the process of reflection I really promote because in Make It Stick they talk about this, and they said there was a medical student. The Make It Stick is not about medical students. It's about all education, but the example they gave was a medical student. They basically said that if you sit there and after you read something or hear something like that, you reflect, you think back, okay, what are 5 things I learned from this? It helps you learn. It helped one medical student go from the bottom of their class to the top of their class. So I highly recommend doing this. I don't give you a summary because of this. I want you to pause and look back and think of what are 5 things I said during the lecture that would be important and you want to remember. And I hope there are 5 things I said that were important. So there's my final one. This is from the bison range again. This is just a deer that was underneath a tree, just kind of cute. So took a picture of it. So I hope this lecture has been useful. Thank you.